Just testing.
Yeah, and that's fine. I don't know if you saw the email. She said that was fine. For particular subpopulations that are most affected by this issue, and in particular, we're going to zero in on those who are impacted by chronic pain, because that's a particular risk factor that I think will be of great interest to you all. And then we're going to talk about what can you do as a health system, what can you do as a community, and what can you do as individuals to support people who are at risk for opioid misuse, opioid use disorder, and suicide. So that's what we're up to today. So we're going to dive right in because we don't have a lot of time. We are going to spend a little bit of time looking at data. And what I want to say about this is that the data we're going to share is national or state Oklahoma data. We know that that is not representative of Chickasaw Nation. Our purpose in sharing it with you is not that we're telling a story that is going to resonate with you, but that we're looking at how can you use data, what kinds of data sources might be available to you to help you understand more deeply what subpopulations are at most risk in your community and how to make sure that you're addressing your intervention to those folks at highest risk. So we know that this data is not representative for you, but we're sharing it with the idea of sort of thinking about how data can be useful in this discussion. Now, a word about language. So we talk about opioid abuse, we talk about opioid use, we talk about opioid misuse, and then we talk about opioid use disorders. The language in the data sets is very variable. So we, as practitioners, have been really trying to move towards less stigmatizing language. So really thinking about opioid use, opioid misuse, and opioid use disorders as being the language we're most comfortable with. But the reality is that lots of the data sets are still talking about abuse. So you'll see that language in here. Just wanted to make a quick comment about that. We're going to zip through the data because it's not the most important part of what we have to share with you today. But we did just kind of want to set the stage. So in this slide that you see, it is a slide for all individuals, so youth and adults, 11.8 million people who abused opioids in 2016. This is NISDA data, so that's the National Survey on Drug Use and Health. There is a brand new set of NISDA data that has just become available in the last couple of weeks. It was not in enough time for us to do the analysis to include it in this presentation, but I would point you to looking for that. And what it does show overall is that things are starting to resolve around this issue, that things are going down. Not early enough for us to declare victory in any stretch, but we are starting to see progress in the right direction. The important takeaway from this slide is that when we're talking about opioids, the majority of opioids that are misused in the nation are prescription opioids. So I think that's often a surprise to folks. So out of that 11.8 million people, 11.5 million were abusing prescription opioids. Where they got those opioids, whether they got them through a direct prescription or borrowed from a friend or were sold them on the street, you know, those are all variables there. But they were, in fact, prescription opioids. And that only 8% of the people who abused opioids were using heroin, were using street heroin, and that only 5.4 of those folks were using both. So what this says to us in our work is that the majority of folks are using those prescription opioids still. What is not as evident here, because we had not been gathering data as much about it, are the synthetic fentanyls that we're starting to see increase in use across the country. So that is not represented here. So if we look at opioid overdose by type in Oklahoma, what we see in the blue bars is that over time we did see a sharp increase in the early 2000s. We had sort of a platform throughout the early 2010s, and we're starting to see it dissipate a little bit as we go into 2016, 2017. Those are the big blue bars, so that's a total of all different kinds of opioids. If you look at the blue line with the little dots, those are RX opioids or prescription opioids. And what we're seeing there is that there is a sharp decrease in those drugs being at the source for opioid overdose. Now, the concerning thing, and I think is probably true for Oklahoma, I know it's true nationally, is that what we're starting to see that's concerning are the rise of those synthetic opioids and the rise of heroin. And why that's concerning is those are far harder to understand dosage about. And so they're often dosed differently, and that's what really creates that spike in overdose. So it just gives you a little bit of a sense of what's important to be looking out for. So we're making progress in some really important ways, but we also have some concerns about where we're headed. So this next slide shows the relationship between opioid prescribing rates and overdose deaths. And I imagine it's not much of a surprise to any of you that the more we prescribe, the more folks are dying from overdose deaths related to opioid use. The less we prescribe, those opioid deaths start to come down. And so you can see that many efforts have been made to reduce prescribing, to have folks do other kinds of pain management, and we'll be talking about those things in just a little bit. This next slide, and again, this is just for Oklahoma, this slide here. The next slide talks about Oklahoma in relationship to the rest of the nation. And so what we see is Oklahoma has had higher drug-related deaths per thousand over the last several years, but it's starting to come down. In the nation, it's climbing. None of this data beyond 2017, we can't see that yet, and those are not huge differences, so we need to keep an eye on how we're doing about that. But the good news is perhaps it's starting to go down in Oklahoma, and that's our hope. So I'm going to pause for a second here. If you have a question you want to jot down on a piece of paper or a comment that you want to share, I'm going to give you a minute to do that. We're going to shift over to talking about suicide and looking at some suicide data next. So I'm just going to take a deep breath, let you do that. All right. So now we're going to move into suicide. So this is 2017 data, again, from that same survey, national data, the NISDA data, and it shows that there's a significantly higher number of people who have experienced serious thoughts of suicide, almost 1 million in a year, and then the number of people who actually attempt suicide is much smaller than that, and those who actually die by suicide is even smaller. What's important about looking at this upside-down triangle, to me as someone who's worked in both treatment and prevention, is that this shows us that there are places where we can intervene before someone has a fatality. So it's really critical that we think about prevention efforts and intervention efforts in the top part of this triangle. So when we hear that someone is having serious thoughts or has made an attempt, those are real opportunities for us to turn things around. And that's really the most important takeaway from that slide. When we look at suicide across the lifespan, we look at where it stands in terms of leading cause of death. So this, again, is not surprising probably, but that it is the second leading cause of death for people aged 10 to 24. So it's a very high leading cause of death for younger people. It becomes the fourth leading cause among 35 to 45-year-olds, and then the eighth leading cause of death for those over 55 to 64. Some of this is simply the natural way things happen, right? That leading causes of death change as we get older. And as an older person myself, I start to see there's a whole lot of other things out there that I might die from rather than taking my own life. So that's part of the concept here, is that health issues become more critically important over time. But it is really important for us to be thinking about suicide as something that happens across the lifespan, and really important for us to be thinking about within our own communities, within our own networks, who is at most risk. I know for myself out here in New England, this is where I'm talking to you from the state of Massachusetts, that we had a real spike in middle-aged white men for a period of time in our communities. And so the data really helped us understand that that was an issue and that we really needed to think about how we were going to make our interventions appropriate to that particular subgroup of people. And so that's why it's important to sort of look at some of this data. And I encourage you to think about what data you may have that would help you understand who's most at risk in your community. We also wanted to share this one. This slide is about suicide by method. And as you can see, the amount of suicides that are related specifically to opioid, and they're classified as poisonings, is a very small amount when you look at the number of ways suicide happens by method. As you can see, 50% by firearm, right? So the important takeaway in this is not that opioid misuse, opioid use disorder isn't an important connector to suicide, but it's not the only thing we need to do if what we're trying to do is prevent suicide. We need to take into account some of these other lethal means as well. Still very important for us to understand this particular connection, but we're not going to reduce suicide overall just by addressing that one particular piece. And so that's an important concept to think about. I so wish that I could have found a map like this for opioid overdose, but I couldn't. I could only find a map that showed me suicide death rates by county in Oklahoma. It's not broken out this way in Oklahoma's state data for suicide, for opioid overdose. So we can't really compare the two. But I do know that Chickasaw Nation is sort of in the middle, southern part of the state there, all those counties. I don't know if I can get my little green arrow. I'm going to try it again. It doesn't seem to want to move for me today. Sorry. No, it's not going to go. But we're looking at some of the deeper purple and some of the dark purple areas where there are higher rates of suicide per county. So you guys know where you live in the state, and you know what counties your nation encompasses, and so thinking about sort of where those sections are where there are higher rates might be something to consider. Great. So as I said, I was going to speed through that data, and I did. And so I'm going to give you a minute now to check in with a partner, talk to each other a little bit about what stood out for you in that data, and what questions do you have about what kind of data you would want to know about Chickasaw Nation that would help you as practitioners either prevent suicide, work with folks who in treatment who are having substance use disorders or suicidal issues. So you have a few minutes now to talk to each other. We'll come back in just a minute or two.
So let's do that.
Thank you so much, you guys. That's great that you had a little chance to chat. So now what we're going to look at is the intersection between suicide, opioid abuse, and overdose. And this is a complicated set of things to look at. So we're going to try to parse it out in a couple of different ways. The reality is none of our data sets show us this easily. So again, we're going to be looking at pieces of data and trying to figure out what's the most, what is it telling us about this issue. So if we look at youth first, we're thinking about youth in grades 9 through 12, so teenage youth, who report having attempted suicide in the past and have also reported some use of prescription pain medication in their lifetime. What we see is that those two things are related, that youth who have used RX prescription drugs, misused RX prescription drugs, and had attempted suicide is significantly higher than those youth who have not misused prescription drugs. So suicide attempts without any prescription drug misuse are much lower than those in youth that have both abused or misused RX medications and attempted suicide. And as you can see over time, 2019, 2011, 2013, 2015, it is creeping up, and so it is important for us to keep an eye on that. Similarly, for adults, we see a similar kind of dynamic, which is that those who misuse prescription drugs and who attempt or have serious, this one is about serious thoughts of suicide, that there is a correlation between those two. And again, we're seeing it starting to creep up a bit among adults as well. So we see that that's consistent among adults and among youth. We do have data for adults around suicide death rates by race. And as you can see, we struggle a lot with the data because none of the data sets really line up perfectly. So we're trying to take data that we think will tell us something. What you notice here is that the use of drugs or alcohol in suicide attempts is different by race. So, and again, it's important to say Native American, Alaska Native, that is the entire, that's writ large. That may not be at all true for Chickasaw Nation. Specifically, that's for all Native American and Alaska Native populations in the nation. So, so we see that alcohol is actually the substance of choice. Among white and Black or African American populations, we see that drugs are the method of choice for suicide deaths. And then we see among Asian and Pacific Islanders that it's not drug-related or alcohol-related, it's something else. So it might be one of those other things in the circle that I showed you early, or firearms, suffocation, or other. And so it just may be helpful to think about this, about what are the lethal means that folks in your community are using, and really be thinking about how you work around that. So overall, what we see is that there is, in fact, a distinct relationship between opioid use, opioid misuse, and opioid overdose and suicide deaths. So if taken as a whole, we see that those have skyrocketed 250% in the last almost 20 years, and that 40% of those overdose and suicide deaths involve opioids. I don't think this is a surprise to any of us who've been working in this field. We know what the problem is. We know it's a big issue, and it's happened to us quickly. What's a little more subtle, and I think more important for us to think about, particularly as practitioners, is the relationship between chronic pain and opioid use, opioid misuse, and then suicidal behaviors and thoughts. So pain by itself, chronic pain by itself, can increase vulnerability to suicidal thoughts and behaviors. And we need to unpack that a little bit. We'll be looking more at this as we go throughout this afternoon. But, there's the obvious dynamic that folks who have to manage chronic pain, it's exhausting, it's challenging, it's painful. All of that might lead folks to feeling like they want to end it. That is certainly a component, but even more than that, some of the ways in which pain impacts the parts of the brain that manage stress and manage impulsivity is also a factor. So it's important to say that managing chronic pain is one aspect of it, but pain itself and the way that it interacts with our neurology also puts people at higher risk for misusing opioids and being at higher risk for suicidal thoughts and potentially using those opioids to, in fact, commit suicide. So we also know, and congratulations, Oklahoma, for being the first ones to really hold the pharmaceutical companies' feet to the fire. That's a huge cheer in the world out there. But that we know that pain management protocols over the last 20 years have changed, and that there's been a huge increase in the number of opioids prescribed per person nationally. It's really incredible when you look at this data, 600% increase in the opioid dosage per person per year in those 10 years between 1997 and 2007. So there it is. That's the problem that we are all managing the consequences of. We also know that those increased dosages, so higher prescribed dosages, relate directly to increased rates of suicide attempts and both fatal and non-fatal overdoses. So the more of these drugs we give people, the higher risk they are for suicide attempts and fatal and non-fatal overdoses. And that the drivers of that opioid use include pain, but also include that increased prescribing and availability, and also the socioeconomic stress that come from potentially having to manage that pain and manage their addiction to these opioid drugs as well. So it's not just one thing, it's multiple things. And as someone who writes a lot of grants in my life, I'm often hearing from funders, tell us the one thing we can do to make this different. And I always want to say back to them, it's not one thing, it's several things. And it's really critically important that we understand that a comprehensive approach is really critical to making a difference in our communities around these issues. So just to reiterate that, so adults who receive high doses of opioids are at an increased risk for suicide. The research proves that that is in fact true. So what that says to us as practitioners is we want to be very careful about when we give people high doses of opioids. We also see from the research that adults who abuse opioids weekly or more are more likely to engage in suicide planning and attempts. So one is that you have higher doses of it. Two is that you're using it more frequently. And then third, if you've actually been diagnosed with an opioid use disorder, which is really a behavioral health condition, that you are 13 times more likely to die by suicide than someone who has not had that diagnosis. So there is a direct link between opioid misuse, opioid use disorder, and suicide. Now, having said that, it's very tricky to try to figure out exactly what those linkages are. We have some ideas about that. We know that higher dosage offer this increase to access to lethal means. So, one of the things we know in suicide prevention and suicide intervention work is that one of the things we always want to do is reduce the access to lethal means. So if you don't have it right in your possession there, it's harder to get to, it's less likely that you're going to go ahead and use that. So that's one piece. The other is that opioids, their interaction in our neurology and in our brains have disinhibiting effects. So that can increase the likelihood that we would act on an impulse for suicide. So the opioids themselves actually contribute to someone being more likely to just go ahead and make an attempt or have a fatal overdose, as opposed to those who do not have that disinhibiting effect. And then finally, those who take higher doses of opioids share characteristics with those who are at risk for suicide generally, and we're going to spend a little bit more time teasing out those shared factors. So we look at these as three possible links. We don't have definitive answers about them, but this is really where the research is taking us. The biggest challenge is that we have this intentionality continuum, right? That we really don't know, was that an intentional overdose or was that an unintentional overdose, unless someone makes it entirely clear to us by leaving a note or something like that. So that's very complicated and very difficult to understand. The data that we collect doesn't tell us where people fit on that continuum. What we do gather is we gather data on manner of death. And as you can see, these are the kinds of buckets that we gather data on. But we really struggle with those last three bullets. So if someone has not made it clear that it's a suicide, we don't know whether it was intentional or not, whether they were determined to do it, or whether that death was from some other unknown cause. So we still have some real challenges in understanding what the data is trying to tell us. We know that there are huge problems in classifying poisoning deaths, that there's not a lot of training for the people that are gathering that data, and not a lot of resources for them to really intentionally understand this. We also know that there's a lot of bias and stigma around all of these issues, and so that oftentimes impacts the data that we're able to collect. And then there's complexities, as we've already talked about, around intent. We also know that suicides are undercounted, and they're undercounted in particular groups. Research shows that these groups on this slide are ones who traditionally have undercounting of suicide. But the reality is stigma and bias impact how all of us collect data on suicide, because there is such stigma around it, and also around opioid misuse. So it is important for us to address that stigma and bias first, so that we can really understand what's going on with folks, and be sure that we're capturing what's really happening. So what does this mean for us? Again, that was a lot of data talk, and we're going to get into sort of what you can do next. But really important to think about for the folks that you're serving, what's the data that will help you understand what that intersection means in your communities? And thinking about how do you collect data both on the method of suicide and the presence of opioids, and putting that data together in a comprehensive way. As well as really thinking about who are the potential folks in your community who can help you with the less number-focused data, but the qualitative data around quality of life and concerns about stress and socioeconomic factors and all of that. And how can you add that qualitative data to really give you a better picture of what's going on? And then really thinking about using that data, not to target people, but to make sure that you've got the right resources in the right place for the folks that are at highest need. And really thinking about building supports for those segments of your community that are at highest risk. So again, I'm just going to take a deep breath and a sip of my water as I give you a chance to jot down a question or comment that you might want to share with us after the webinar. All right, and then we're going to spend some time looking at shared risk factors, and then we're going to wrap up with what folks in health systems can do. So in terms of, I'm starting with opioid abuse. Sorry, I lost my slide for a second there. So in terms of opioid misuse and opioid use disorder, what are the factors that increase risk? No surprises here, right? Physical health problems. If you have chronic pain, if you have migraine headaches, it's very likely that you may be prescribed some of these drugs in order to manage that pain. No one is saying that you shouldn't do that. It's just that we need to be real about paying close attention to how that elevates risk. As well, behavioral health problems, depression, anxiety, other kinds of behavioral health issues put folks at higher risk for opioid misuse and opioid use disorder. Past incarceration is another factor, social isolation, of course the relationship between trauma, adverse childhood experiences, multi-generational and historical trauma, all of those are a factor that increase risk, as well as parental or caregiver favorable attitudes. We know that that's been true around youth prevention for years, that if children grow up in an environment where folks are very laissez-faire around substance use, that they're more likely to try. So again, probably not a huge surprise for you in this information. But now we've layered that onto suicide. And as you can see, there's a lot of similarities, right? Those physical health problems, behavioral health problems, social isolation, and trauma are all common factors. It is important to point out that a history of non-suicidal self-injury, so potentially a person who has in the past engaged in cutting behaviors or other kinds of self-injury behaviors, maybe someone who later has a higher elevated risk for suicide, someone we want to be paying special attention to. And then that piece about access to lethal means is particularly important when we look at suicide. So when we put them together, what we see is that physical health problems are shared factors, behavioral health problems are shared factors, trauma, adverse childhood experiences, and that whole experience is a shared factor, as well as social isolation. So Wanda, at the end of the webinar today, is going to point you to a wonderful resource called Mental Health First Aid and how to get access to training around that. A really important piece, I think, for folks who are working more in the substance use field that don't automatically have training in behavioral health issues, really helps to kind of bring that language together and help people work together around those issues. So I love this slide because when I was working with Deanna to put this presentation together, she said, it's all about this slide, and I couldn't agree with her more because at the end of the day, this is what heals, right? Building connections, building a network of caring around people who are struggling is always what really helps people get better. And so building connections is what we're really about when we talk about building a more coordinated response. So we've talked a lot about data today, and I think it's important to think about what are the conditions? Why is it happening here? Why is it happening now? And really be thinking about how do you get ahead of those conditions so that you can work on those prevention efforts. It's also really important to engage leaders, right? Engage leadership in your various work, to talk to each other about building structures, networks, systems that help people talk to each other. I know when I was in substance misuse treatment that I never got a chance to talk to pediatricians, although I was working with children, young people. And there was such a silo between the work that we did and folks who were doing physical health things. We really want to break those silos down, because that's where that really important building connectiveness around individuals happens. And then thinking about within your own work, how do you build partnerships with folks who do different work in your healthcare system, so that you have somebody to go to and say, hey, I'm not really a behavioral health person, but you are, and can you help me look through that lens at the issues I'm concerned about this person I'm working with? So that's really critical. So I'm excited to share this one. So I know that you guys have some substance abuse prevention specialists out there in Chickasaw Nation, and I don't know if there's any in the room today. Deanna, I know you're one, but if there's others, could you raise your hand so folks can see you? The preventionists are always really wanting to make sure that we're hooking up to the folks that are doing interventions and treatment. So hopefully there's some preventionists there in the room. And this is just a slide that talks about how we do our work in public health and prevention. As you can see, we talk a lot about data. We try to figure out what the data can tell us about where our interventions need to be focused and where they need to be housed. We also really want to work on both helping people stay healthy, what we call upstream interventions, so that we just keep people in a healthy place and we don't need to worry about having to intervene with problem behaviors. But we know that that's not enough, that we also need to work with those folks who are working more downstream on harm reduction efforts, on interventions that help people get back into recovery and onto a healthy path. And overall, our aim is always to reduce deaths, morbidity, and mortality. And we do this by really trying to figure out what the data tells us about the problem and identify those risk and protective factors. We then develop and test prevention strategies for effectiveness, and when we find something that works, we try to make sure that it's getting out there into the world and everyone is adopting it. So what can health systems do? So that's what prevention can bring to the table. Let's turn now to what health systems can do. So one of the most important things, and we know Chickasaw Nation has done some of this, we'll talk about that in just a minute, but we know that it's really critical that the folks that are working with folks with chronic pain, or those pain specialists, are really connecting with primary care providers, and that both have good validated screening and assessment tools to screen for both suicide and overdose risk, opioid overdose risk. So making sure that everybody has access to good validated screening tools and assessment tools, and they know how to use them and they're comfortable using them. The other place I think is critical, and I know that Chickasaw Nation has done some work on this, is really thinking about the places in between, because where folks are at most risk are when they come out of an inpatient setting is a huge place where folks are at risk, or when they're transferring from one provider to another provider. And so it's really important that we think about those transitions and we build safety plans around them, as we're always working to reduce access to lethal means. So that's one really important thing that we can do. We can also increase the use of non-medication-based strategies for pain management. So that can come everywhere from cognitive behavioral therapy to complementary or alternative approaches, meditation, mindfulness, yoga, acupuncture. Traditional healing practices in tribal communities can be a wonderful asset in non-opioid related pain management. So really thinking about how do we up opportunities for folks to do things that aren't going to end up putting them in higher risk. And then the other piece is really engaging everybody in the conversation. So it isn't just us folks that are in healthcare systems or preventionists or treatment or folks who are doing intervention or recovery, but that employers understand these issues, that folks in spiritual communities understand that everybody sort of gets a handle on what we're trying to do here. And we support all of those responses that do not depend on opioid use. to support people and build those life-giving connections that we hope to see. So if we look sort of at an individual and we think about where is that individual in our healthcare system, one of the things we want to make sure is that they have access and they're getting a good, solid care delivery plan. So if someone's really isolated, we want to bring them in and connect them. If they're in our healthcare system but their plan is kind of all over the place, we want to streamline that and help that be more of a continuum. We also want to create connections for people that aren't related to their relationship with a health provider. So where can people get support in their community? Can they go to a support group? Is there a recovery coach? Where are the supports that we can build around that individual with family, with friends, and with support groups? And then thinking even further out, how can we create community environments that really support health and reduce risk for both opioid misuse, overdose, and suicide. So really building protective communities and protective environments. And then what can we each as individuals do? One is to learn for ourselves coping and problem-solving skills and then share them with each other. That's really critical so that we have not just one or two strategies, but we have a whole toolbox full of things we can do when we're having a hard time. We can be the ones to connect and support people at risk to the right support system. And if we all sort of did that with two people, that would increase that network of support immensely. And then we can always be thinking about what do we need to do to build a more protective and a less risky environment for our young people to grow up in, for our people who are challenged by chronic pain to live in, and for our elders to have a peaceful end of life in. And those are really important pieces for us to consider. So I have been talking at you a long time. I did just want to mention that Chickasaw Nation was part of the Zero Suicide study, and they implemented it from 2015, I think, for 2 or 3 years after that. And out of that work came standardized screening, comprehensive suicide risk assessment, collaborative safety planning, and follow-up care. Are there any folks in the room, again, I'm going to ask you to raise your hand, if you were involved in this Zero Suicide study? So folks, look around and see if you can see those people. They may be able to provide some additional information for you. Was a very successful initiative and I think showed great promise. So building on that work will really move you forward. And it is really important to think about the idea of no wrong door for folks, right? That wherever they come in contact, if they've shared their risk or their concerns with someone, that person knows exactly how to go to the right set of services and get that care for someone. And so the great news was that through this study, they found better outcomes for patients and that all-important cost saving for the healthcare system. One piece that I pulled out of the study that I thought was so critical is this quote, and I'm just going to read it to you because I think that's probably the best way to do it, is, the more we've listened to our patients and reviewed relevant research, it is evident that inpatient treatment is not always a viable option to ensure improvement and success. Additionally, it adds a critical risk window once they discharge that we can avoid if we find another way to support those folks. So one of the most important things about that data and that study and research that we've talked about is that sometimes the traditional response, right? Oh, somebody said they're suicidal, let's put them inpatient. Sometimes that slows us down and says, wow, is that really the best answer for this person? And maybe there are other ways to go about this that actually would help us with risk further down the line. Because as we talked about, once someone is discharged, that's a very, very risky place for them to be. So I just wanted to share those outcomes if everybody there didn't already know them, and I thought this was a really important learning. So we're going to zoom through the partner chat because we're running out of time. Again, give you just a pause if you have a question or a comment that you'd like to share with us, that you'd like us to respond to. We'd love to do that. We're going to take you into our wrap-up now. And Wanda, I'm going to turn it over to you to talk a little bit about mental health first aid, which I've already mentioned a little bit.
Yes, thank you, Dodie. Dodie talked about mental health first aid, and those of you who have not taken it, it really does address these two topics that we've talked about today. Opioids is part of the new curriculum that will be coming out soon, and there's an opioid supplement for those of you who haven't taken it. And just an amazing curriculum. We've just recently been trained in this, and so I encourage you. We've got a link here to find a course, and all you have to do is put in your location, and it will tell you the courses that are available near you. There's a youth mental health first aid, and there's an adult mental health first aid. For those of you, the youth is meant for adults that are working with youth. So there's that. And then I told you that I would let you know about additional prevention training and let you know our website for the PTTC network. And so here that is, pttcnetwork.org. And again, you can go there and you can select any training center. Yours is the South-Southwest, but you can select any training center and look at the training that they have available and take it. There is a website for online courses. Right now, the only one we have available is the SAPS online course, and we encourage all of you to take that. It's the Substance Abuse Prevention Specialist Training, and that will be available until September 30th. So if you are interested in that, I will put my email up, and you can email me and I can let you know how to access that. But definitely, those of you who are preventionists, you can get those prevention hours for certification. So back to Dodie so she can give us some additional resources for the presentation.
Great, and I know we're down to our last minute, so I'm not going to read all these resources to you. We will ensure that Deanna has a copy of this presentation and it gets to all of you. She has a sign-in sheet and we have a sign-in sheet. We'll make sure that this is available as is the recording. So I'm just going to say on these slides there are a number of different resources to share with you if you'd like to continue your learning. I do want to give the last minute to our wonderful colleague in the room, Sheila, who will be doing an evaluation.